Good evening and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our webinar series that was developed for individuals that have suffered from concussion, their families, as well as healthcare providers. And if you've been with us before, you know that the sessions focus on various aspects of concussion, and it starts off with an expert speaker who will be presenting for about half the session, and then you can get your questions answered in the second half. I would just like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we are meeting virtually, I'd like to take a moment to acknowledge the importance of the lands which we each call home, to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So in terms of the concussion webinar series, if you have not been with us before, just to let you know, all of our presentations are archived and located on the website, so you can go back and watch previous webinars if you would like. Just with regard to this evening's webinar, if you look to the bottom of the screen, and just move your cursor down, you'll see that there's a Q&A icon. So if you do have any questions this evening, please enter those there. And if you have any technical difficulties, you can enter those into the chat. I believe Christian has already posted the link to the webinar series as well, if you're interested in that. We're going to just run a very quick poll, as we always do, just to get a sense of who is in the audience. So I'll just give you a second to do that. Perfect. And for this evening's session, I'm really pleased to welcome back Dr. Dave Gold, who's presenting neuropsychological assessment in persisting concussion symptoms, how brain injury affects thinking. Dr. Gold is a staff psychologist at Toronto Western Hospital. He provides neuropsychological consultation for the epilepsy program, primarily, as well as other divisions of the Krembil Brain Institute, such as the Canadian Concussion Centre. Dr. Gold is an assistant professor in the Department of Psychiatry at the University of Toronto and enjoys teaching and supervising clinical psychology trainees. His doctoral and postdoctoral research examined event cognition and the cognitive neuropsychology of aging, while his current research interests include questions about the cognitive neuroscience of memory and the intersection of neurology and psychiatry, such as ADHD assessment and treatment. So with that, I'm going to turn it over to Dr. Gold.
Okay, thank you, Leslie. So I'm excited to talk to the group tonight about concussions. And yeah, so we'll talk a little bit about neuropsych assessment and how brain injury affects thinking skills. And so starting off with our learning objectives, what I hope to impart today is understanding how various regions of the brain contribute to thinking skills. So I feel like a greater understanding of how the brain works and how it produces cognition can give us a sense of empowerment and a sense of understanding about our brain. And speaking about how our brain can be injured and what happens to thinking skills. So we'll talk a little bit about concussion in particular and what can happen to the major cells in our brain, the neurons. And we'll also talk a little bit about what we do in neuropsychology. So it's a branch of psychology where we evaluate thinking skills. And so we'll talk a little bit about what are some of the tests we use? How do we assess thinking skills? So to give you a little bit of an overview, the first thing we'll start off is how do we go from neurons to cognition? So how do we go from a brain to thinking skills? And the next part of the talk will be focused on how brain injury impacts thinking skills. So we'll talk a little bit about the brain and how a brain injury can impact thinking skills. And then we'll spend the last part of the talk talking about, well, how do we measure it? as a psychologist, how do we assess, evaluate, psychometrically classify cognition? So, beginning with cognition, in terms of the brain, we can divide it into major regions. And the front part of our brain is the largest part of our brain, and it's called the frontal lobe. And that area is most closely responsible for executive function. And so we'll talk about executive function tonight. And that's a term that refers to being the CEO of the brain. So it refers to being mentally flexible. It refers to organizing and planning and switching and shifting. Sometimes I like to call it being the mental ballerina of the brain. And that's associated with the frontal lobe. Another part of cognition is seeing the world, and that's the back part of our brain, the occipital lobe. And another part of cognition is associated with the parietal lobe. And when we think of parietal lobe, we can think about mentally rotating things in space or doing things like building blocks or copying things, so visual spatial skills. And the temporal lobe is another important part of the brain. And a good way to think about it is that's the important part of our brain for both memory and language. And so that's just a large scale overview of the brain and what parts of thinking are associated with it. But it doesn't really tell us how does our brain kind of produce thought. And so that starts at the level of neurons. And so neurons are the major cell in our brain that is the mechanism by which the brain communicates information. And so the way two neurons talk to each other is by sharing neurotransmitters, and they send a message to another neurotransmitter. They send a message to another neuron through a neurotransmitter. So if someone were to take a medication like selective serotonin reuptake inhibitor, an SSRI for anxiety or depression, this is the mechanism by which it acts. It tells neurons to talk to each other differently. And then over a broader field, we see that neurons communicate through each other in networks of connectivity, and their communications can be sped up with an electrical signal instead of a chemical one. And then over the course of the brain, we see that those networks can congregate and become regions associated with transmitting information. And so we'd have a network in the temporal lobe, a network in the frontal lobe, etc. But in order to think, we need to have these neurons talking to each other in a very synchronized way. So we can't have random neuronal activity. We need to have really orchestrated, well thought out cognition by having neurons talk to each other in a specific way, using kind of like a communication pattern. And so these little nodes represent areas in the brain, and the brain talks to each other by sending signals through neurons to different nodes in the brain. And so those nodes refer to regions that are active at any one time. And so you can imagine it like a spider web where you have interconnected nodes, and those neurons are talking to each other with signals over nodes. And so they're talking to each other within smaller areas, and they're also talking to each other within broader networks. And so I put up this cartoon of a symphony to remind the group that this activity has to be highly orchestrated. So it needs to be timed really well. It needs to be, everyone needs to be listening to one another. And one part of the orchestra can't play over the other. We need to have really well-timed neural activity to enjoy the benefits of cognition. And so I've started to think of the brain more like a race car. And I'll tell you what I mean by that, that the brain is something that is a nimble part of our body. It's an organism that requires a lot of energy. And so when we think about getting a race car up and running, it takes a lot of kind of tools and equipment and service. It needs oil, it needs gas, it needs fancy tires. And so it takes a lot to get one of these race cars up and running. And especially if we think of something like NASCAR. And that's similar to our brain. Our brain is really sensitive to the environment that it's in. So if our brain is tired or if our brain is hungry, and when I say our brain is hungry, I mean our body's hungry, if we're experiencing kind of sadness or stress, so if our brain is feeling affectively different, those are all reasons that our brain wouldn't run as well. So, for instance, if that race car had a tire that was malfunctioning or inadequate oil or some other mechanical issue, it impacts the whole functioning of the brain or the race car. And so our brain is a reflection of all the different factors that are going on. And so it's a sensitive ecosystem. And so that in part explains why when we have an injury, we feel it or experience it in so many different ways. And so when we disrupt the way that information is transmitted in the brain by a brain injury, we could think of the brain as being bruised or injured. But one way to understand why that might impact cognition is that the way that the neurons are talking to each other in the brain is disrupted. And so some pathways are no longer available, or some members of the orchestra aren't playing in the way that they were previously. And so we're not getting synchronized or efficient neuronal communication. And the end product could be changes in the way that we're thinking. And so theoretically, when we imagine how a brain injury could impact the neurons, we think that neurons could be stretched out or even injured and experience a certain degree of shearing. But we usually don't see that level of injury. That's more at the level of the theoretical. In terms of what's more commonly experienced, we see more smaller levels of injury. And so what I mean by that is that the events are at a very microcellular level, that things like extra toxins that aren't being cleared out or inflammation that's mild, as opposed to seeing neuronal damage if you were to do some sort of scan or test of that sort. And one thing I want to highlight to the group is that concussions don't just directly impact cognition, they also can impact cognition through mood. And so for anyone who's experienced a concussion, you can know that sometimes my clients will tell me that, my mood feels different. I feel not like myself. I can feel down. I can feel irritable. I can feel stressed. I can feel anxious. And so we know that concussion can impact cognition either directly or indirectly. And so I put up this slide here of what a brain looks like when it's depressed versus non-depressed. And what this kind of image shows us is that we see different patterns of brain activation in someone who's experiencing depression versus someone who's not. And we can trace that back to the level of neurotransmitters. But it's a reminder that if someone's experiencing a concussion, it's not only that there's disruption at the level of the neuron in terms of that theoretical model of a neuron being sheared, but also there's changes that are secondary or indirect, like the experience of depression. And I put up this slide here of a normal brain versus an ADHD brain versus a depression brain versus an anxiety brain versus a migraine brain, just as an example that crosses over different modalities, whether it's specialized imaging or EEG, to show that different types of broad conditions of neurological functioning can impact cognition. So in this model furthest on the left, we see the normal brain as showing an average amount of activity, whereas in ADHD, we could see theoretically that there's more activity in the front part of their brain. In an example like depression, we could see an example of underactivation. And it just highlights to the group in terms of understanding the relationship between mood and cognition, that there are different ways that we can be experiencing things that can impact how we're thinking, not just from the concussion injury, but secondarily through things like changes in mood. So our brain is sensitive to its emotional environment as well. And I put up this slide here to remind the group that concussions are multifaceted. So individuals can report things like a lack of initiative or difficulty sleeping or light sensitivity or feeling as though they don't have the same kind of mental or physical stamina or difficulty with memory. And so these are all the ways that a brain that's recovering from a concussion can show different types of symptoms. And so that's not one symptom, it can be a lot of different systems that are impacted either directly or indirectly. And so if you were to predict what type of thinking skill could be impacted by a concussion, we have certain predictions of the more common types of thinking skills. But as that last slide should hint to the group, there's a lot of different ways that thinking can be impacted. It could be difficulty sustaining attention. It could be feeling like we're slowed down in our thinking, kind of like a computer that's been on for too long and it seems to be lagging. We can feel like it's hard to exert mental effort for a long period of time. It could be hard to get new information into memory. It could be hard to do two things at the same time or find words to express what we're trying to communicate. We could also notice in terms of feeling difficult adjusting to things or being mentally flexible or switching between tasks. And so there's a lot of different manifestations of changes in thinking skills when people experience a concussion. But as a reminder, executive function seems to be one of the more common ways that people report changes in their thinking skills. And the part of the brain that we think about that it's associated with is more towards the frontal lobe. And so when we think of executive function, we think of being the boss or the CEO of one's brain, trying to multitask and start one task and keep track of another, potentially multitask and do more than one thing at a time or keep track of priorities. Those are types of skills that we think of that are associated with executive function. And of the different types of thinking abilities, it tends to be the most diverse. So there's a lot of different aspects of executive function. And so how do we assess that? How do we measure this construct that I've described to you? And so that is the detective work of neuropsychology. But for the group, here's an example of the ways that we assess something like executive function. And one type of executive function is reasoning. And so here's a reasoning test. So one question might be, well, which pattern below best completes the series above? So A, B, C, D, E, or F, which one of those best completes the pattern above? That looks at our ability to logically deduce information and complete a pattern based on some sort of appreciation of a principle. Another type of problem solving or reasoning could be asking people to abstract. And so what does it mean that sunlight's a great disinfectant or every cloud has a silver lining? So seeing if people can reason through those types of verbal prompts as well. We could think of it as a type of problem solving where we have to navigate through a maze and getting from one start point to an end point. We could also think of it as problem solving the way we might have back in grade school, where we have to make a calculation of some sort and reason through how long it would take to get somewhere based on how fast we're going and the distance traveled. And another type of cognition is attention. And so we could think of attention as kind of what we can hold on to in the moment. And so one of my tests of attention, I'll ask people to try to potentially hold on to pieces of information in mind. And so I might ask, okay, well, can you repeat back the order that I've presented those different crosses? Was the yellow one first, and then the purple, and the red, then green? And so it's not yet memory. It's more of, can you hold on to things within your own personal working pad before it goes into memory? And so I might ask you to manipulate that information. I might say, okay, I want you to remember these numbers. And as you're remembering these numbers, try to keep adding on to them or subtracting. Or I might ask you to only state the number that's one back from the one you've heard or two back. And so by doing that, we're kind of measuring what can you hold on to and manipulate. Another type of multitasking could be asking people to focus on a couple things at the same time. So we might ask you to find particular designs in this array that match a principal. So I might ask you to cross out all the circles, or I might ask you to find all the even numbers and circle them as well. And so you'd be responsible for doing two things at the same time to see if one of the tasks might suffer or if it's hard to do two things at the same time. We might ask you to find particular numbers amongst distractor numbers and to go across the line and kind of circle particular numbers, or maybe there might be one target number and your job is to look at all these different arrays and find that target number. And so you have to not look at other numbers or ignore the letters and find the number that's the target. And so there's a lot of different ways that we can measure that. And yet another type of thinking skill is inhibition. And so because we're virtual, I'm not going to do this one. But for instance, in this test, I could ask you to clap every time you hear a particular target. And so for instance, I could read a list and maybe on that list is a whole bunch of fruits and vegetables. And maybe I could ask you to clap every time I say something that's not a fruit or vegetable. And so you have to inhibit a response. You have to not clap at particular points. And you also have to activate a response as well. And so inhibition refers to kind of being able to mentally hit the brakes or stop when you need to. And that's a type of executive function that can sometimes be impacted um, by a concussion. And in everyday life, we sometimes have some minor failures of inhibition. And so one example could be that you mean to say something and you accidentally swear and you say, oops, I tried to stop saying that, but I couldn't. And so a certain degree of having difficulty inhibiting is a normal part of life. Whereas if someone really struggles with inhibiting, that would be considered a problem with inhibition. So I talked about how concussions can impact processing speed. So we're curious about processing speed. And so that refers to how quickly your brain can transmit information. And so one example of that could be a reaction test where we see how quickly you could do something. And so in this example here, I have the cue of go. You hit the space bar and you don't do it when you see the wait. You have to kind of press the space bar as soon as you see the go. And so there's a lot of different ways of measuring processing speed. So we could do it with a computerized task, or we could do it with a paper and pencil task and time how long it takes. An important part of thinking skills is memory. And so people are very aware of their memory in my experience. They tend to be familiar with it and monitor it and be aware when they're having trouble either getting things into memory, which we call encoding, maintaining things over time, which we call storage, or getting things back out of memory, retrieving information. And so concussion can impact these processes. And so one way we measure memory is to give people word list learning tests where we say, okay, here's a list of words. I want you to try to remember these words. And because we're in a virtual format and I'm presenting them to you, I won't test anyone's memory for them, just to show you that that's a type of memory test to present people with words. And some of these tests we warn people and say, I'm going to test your memory for it. So get ready. Or sometimes we like to do it as a surprise to see how much you could remember when you're not even trying to remember information. And so you might be asked to recall the items. And so recall would mean if it's just up to you and no one's giving you any help, how many of those words can you remember? And so that would be free recall. And then the other type of way we assess memory is to say, well, was that item on the list? Yes or no? And so by doing that, we're actually helping you to find that within your own memory bank to see if it's something that you recognize or not. And if you don't recognize it, we could say fairly confidently that that piece of memory is not something that's recoverable. It's something that was truly forgotten. Another type of memory that we can assess is visual spatial memory. So these are all visual spatial prompts. So we have things like a triangle, a cross, a circle, and we might ask individuals to try to copy them. And so we'll present them for maybe 15 seconds and we'll say, okay, I want you to try to do your best to copy those items. And I might ask you, well, which of these items was on the list? And you'd have to identify which ones were the targets, the ones that you've been presented with, and which ones are tricky lures. So my way of trying to kind of lure you into endorsing the wrong item. Another type of thinking is called naming. And so in this test, I might show you some pictures of items, and these are some common everyday items. And I might ask you to come up with the name of it. And so that refers to naming. And some people after concussion can feel like it's hard to find the word they're looking for to express themselves. And so this is how we would measure it. And so the way we put those thinking tests together is we start with a clinical interview just to understand what you've noticed in daily life, because there's so many different ways that concussion can impact thinking skills. We want to know what you've noticed. And so we'll start with a clinical interview, find out what you've noticed, what you've experienced, and then we'll design a test battery with measures that are appropriate for assessing the things that you've noticed. And so those are the paper and pencil tests that I just showed you. And then we also give you feedback about how you've done on those tests. So which tests were better, which tests were weaker, and what does that mean in terms of your health and your injury and your recovery, potential strategies that you could work on. So getting a sense of how you're doing with thinking, similar to going to your family physician and doing a yearly blood test just to see the different levels of blood and the different levels of different things we're measuring in the blood. So has your, vitamin B levels changed over time? Maybe you're feeling a little bit fatigued, or do you have kind of a reduced thyroid hormone? And so we can do that with thinking by saying, well, relative to your other thinking abilities, is memory a little bit weaker, or is your processing speed a little bit weaker? So by doing that, we're kind of doing a blood test for the brain. And so the way we do that is we look at particular scores on the tests and we compare them to yourself. So we look at your intra-individual strengths and weaknesses. So how have you done relative to your own strengths and weaknesses? But also, how have you done on the test relative to the population? And so we have two different comparisons there. And so an example of what a pattern of cognitive strengths and weaknesses could look like would be this one here, where maybe in the area of executive function, you're having a little bit more trouble. So more of those scores are in the below average range, whereas in memory, the scores are mostly in the above average range. And so that might be a relative strength, whereas processing speed's about average. And executive function, we talked about, is at the kind of lower end of the normal range, whereas attention is also in that similar range. And visual spatial abilities seem to also be average. So in this hypothetical example, this person's having relative weakness in executive function and attention. And so I refer to a relative weakness when a score isn't impaired, but it's kind of someone's weaker score within their own strengths and weaknesses, whereas something might be considered an impairment if it's truly something that's within the impaired range. And so we start off with this interview, we pick the tests that we think address the question that people have, and we look at their pattern of strengths and weaknesses. But we also face some challenges in neuropsychology, and not everyone speaks English as a first language, or they've come here from different countries. Some individuals have a really high level of functioning, and so it can be a challenge to see how they're doing in terms of their strengths and weaknesses if they're a very high functioning individual. Sometimes people come to us having done a single test in their physician's office, and it feels as though a lot of conclusions have been drawn from it. And perhaps that one test, that one testing environment doesn't best represent their performance in a reliable way. It might not even be valid for some people. And another challenge is that maybe people have done that test over and over again and they've started to practice for it and they're very familiar with the test. So shouldn't they be getting better at this test, not worse at it? And it can be hard to assess how people are feeling and how that could impact cognition. So we have specialized training in appreciating how is someone's mood impacting their thinking skills, as well as sensitive tools to capture and diagnose different types of mood presentations that could be impacting cognition. And so the way we handle the challenge of different cultures and languages to try to use culturally fair or materials that don't particularly penalize people for having different backgrounds. So an example would be that word learning test that I showed. That wouldn't be fair for someone for whom they're not fluent in English, and maybe that visual spatial test would be a better measure of their memory. Or maybe it'd be better to work with an interpreter and to have that test interpreted into the language they feel more comfortable in. For individuals who have a high baseline, we tend to use our most sophisticated measures to really test their upper limits. We try to optimize the testing environment to make sure there's not just a single test. And we have ways of kind of calculating and working with how to interpret multiple tests. And we have those sensitive tools for being able to understand the role of mood and cognition. And so at the end of the day, the type of feedback we give is this diagnosis from a cognitive perspective? Like, does the cognitive strengths and weakness fit with other information? So other information could be individuals' brain MRIs or EEGs or their medical history. Those are examples of diagnoses that we can make based on other information. We can also comment on if secondary factors are impacting thinking skills. So for instance, a recent client of mine was using particular substances that I think were impacting their thinking skills. I can think of another example of someone who had a pretty dramatic change in their sleeping patterns, and I thought that the types of thinking strengths and weaknesses they were showing were more consistent with someone who had disrupted sleep as opposed to difficulty due to a different medical condition. And we can also identify things that can be changed. So in that example I just gave about sleep, making the recommendation of doing a sleep study if a formal diagnosis of some sort of sleep condition like sleep apnea and optimization with some sort of treatment like a CPAP machine to ensure consistent oxygen flow overnight. That would be an example of a modifiable target. And so we also comment on prognosis. So prognosis refers to, based on someone's thinking skills, what does the future look like? And so that could mean, is this person ready to return to work, or do they seem to be recovered back to their baseline? And so can we comment on how things are recovering or going? So we don't predict the future, but we're kind of giving a sense of how this person's recovered or what stage they're at in their recovery. And so, why don't I stop there? I left quite a bit of time for discussion, and I'm happy to go back to particular things that people might have questions on, or to address things that have come up with the group.
Great. Thank you so much, Dr. Gold. That you did an amazing job of summarizing all of that. We do have a few questions. So just a reminder to everyone that you can enter your questions into the Q&A. And just a reminder as well, we had a question in the chat from someone who had to leave early. So you will be able to access this probably within a week. And all of our previous presentations are also archived and online. And Christian had posted those in the link or in the chat. Okay, so first question, Dr. Gold. I think they're wondering what the imaging modality was that you were showing and what inferences can be reliably made from them. We used to say that if a plain MRI or CT was normal or abnormal, then definitive conclusions could be made. But we now understand that was an overreach.
Mhm. Yeah, so it's a good question, and I would say that there are different types of technologies that we can use, and to date, there's not a gold standard measure of concussion based on technologies to assess the brain, like EEG or MRI or MEG or functional MRI or a PET scan. Some of these different technologies do show patterns of activation, or they do show at the level of research that there are different patterns of brain activity that can be associated with concussion. So, in terms of drawing inferences from medical tests, we're not yet able to kind of provide a test that validates your experience of a concussion, for instance, or in the context of sport, can be used to say this person is 100% recovered from a concussion, or this person is 100% still experiencing lingering symptoms from concussion. So we lack the precision based on those technologies, but they are hopefully in the future going to be leveraged as a way of better understanding that even if a CT or an MRI looks normal, one can't infer that the brain is functioning normally. I think we can do better as a profession at being able to capture the brain that's still recovering and has more micro changes, perhaps in the way that neurons are communicating with one another, perhaps at the level of very small patterns of inflammation, or even at the level of how the blood responds to different types of kind of stimuli that if we give a functional MRI and look at how the brain is activating, being able to capture if there's a different response in concussion that captures a brain that's either recovered or not yet recovered from concussion.
Great. Thank you very much. Sarah is asking, she says, as I listen to your presentation, I am nodding, especially about memory. Please share about the permanence of neuropsychological changes we experience with concussion. In other words, what percentage of change can I expect to see um, with the work that I am doing to resolve issues paired with the recovery that my brain organically does for me?
Mhm. So, I'm glad I have Leslie on the call as well because I might ask for her perspective as well. That we hope for complete recovery from concussion, that individuals recover all the way back to their baseline. And I think what we know, though, is unfortunately some individuals do have lingering cognitive symptoms. And my best rubric that I work with is that when individuals are still experiencing physical symptoms of concussion, like light sensitivity or reduced cognitive stamina or headaches, that during that period where they're still having physical symptoms, the cognitive symptoms can still be present. But when individuals report feeling that those have resolved, their cognitive symptoms tend to resolve as well. It's not 100% guarantee, nor does everyone recover to the full baseline level. But that's the way that I think about it.
Hmm. Yeah, I would absolutely agree. And Sarah just said yes, thank you. Okay, next one. Thanks for doing this. I still feel like my cognition is affected, so especially attention, ability to focus, can't multitask like I could. Memory isn't as good as it was and also much slower. Yet I am showing good results on these tests that are being done. So it sounds like they've had some neuropsychological testing. And it's these results that are being used in reports that dictate my return to work plan,
Hmm.
even though the test is done in an environment that is very different than work or home environments. Is there anything I can do to make it clear that this is still not my normal functioning besides just saying so?
Yeah, it's a great question that I hear from a lot of the clients, patients at the Canadian Concussion Center that they feel as though they're almost in this adversarial role where they're being asked to defend their symptoms. Like these aren't evident on testing, so is it true that you're experiencing them, or are you exaggerating symptoms, or are you, trying to trick the system, so to speak? And I really don't like that because I think that it puts people who've experienced a medical event in a really uncomfortable position of trying to explain why they're suffering, and then the medical profession says, no, you're not suffering, and we think you're not being honest. And so I don't like that type of dynamic. And so what I would say is that it's really important to work with a neuropsychologist who's very comfortable with the population and can test in certain ways that capture your cognitive concerns. So, for instance, using tests that are challenging or that are geared towards the type of cognitive complaint that you're experiencing, and who also advocates for you. So the types of cognitive difficulties that you're describing are the ones that are very common in concussion. And so sometimes when I'm writing letters of recommendation or writing to insurance companies or to employers on my patient's behalf, I'm describing the type of cognitive symptom that they're experiencing and how that is related to concussion. And even though that's not necessarily reflected in the test score, that is something that I do believe is present that does need accommodation. And so when we take someone into a test room, we sometimes remove the distractions of daily life. They're sometimes working with a psychometrist who's telling them when to start and when to stop, or the best strategy to approach a task. And so sometimes I've joked around with my clients that we should do neuropsych testing right on Queen Street with a whole bunch of distractions and streetcars going by and people yelling and being able, it's difficult to hear at times, or the weather might change, or something interesting might happen. And that's more real life than a quiet test room where we're removing distractions, someone's coaching you, trying to get your best performance out. And so I think we have to advocate for people and say why our test scores might represent what they've noticed in daily life and how it might underestimate it or even overestimate it in some situations. So I think that would be my answer. Yeah.
Hmm. Yeah, I agree. Thank you. How are tests and results used with people who are typically outside of the normal population range, so high or low baselines, pre-concussion?
That's a great question. And so I imagine having a guitar tuner and kind of raising an octave or lowering an octave, you have to change your expectations for the range that you're in. And you have to be careful about the tests you select, that they have the necessary bandwidth to be sensitive at either the very high range or the very low range. Otherwise, you might have floor effects that scores are close to the floor, so you're not sensitive to lower performance. Or you might have ceiling effects where you're not sensitive to the upper range of performance. And so it's a matter of selecting tests with a range that match the population that you're trying to address. And once you have that range, picking measures that are appropriate to give you strengths and weaknesses within either the lower band of performance or the higher band of performance.
Great, thank you. Next question. How do we get neuropsych assessments affordably as there are no longer psychologists in the system? And what would indicate that we should get one even if we have to pay out of pocket?
That is a great question. And I'd be curious about your experience as well, Leslie. We are at Toronto Western Hospital, one of the few hospitals that have neuropsychologists, and even then it's a challenge to see the patients from the Canadian Concussion Center. We're not able to see all of them, and it's something that I wish was different. But I would say there are specific situations where the neuropsychologist can be helpful, and that's in situations where physical symptoms seem to be improving, but cognition is not. So that's an example where understanding particular patterns of cognitive strengths and weaknesses can be helpful for diagnosis or recommendations. Instances where there is a discrepancy between how people are performing in their doctor's office and how they're functioning in a different environment like school or work, and how accommodations could be helpful to address that discrepancy. I think in instances where the symptoms are lingering or not resolving, or there's a complex recovery, neuropsychologists can be helpful. And so I think talking to your concussion care specialist, whether it's neurologist or family physician, in those situations can be important. And I think there are a different range of neuropsychologists, and some do work on sliding scales. And so trying to find someone who could work with you if you don't have access to insurance coverage, to try to make the process affordable. So I do think there are options, but it's certainly not easy, and I personally wish it was different.
Hmm. Yeah, I agree. It isn't easy, but yeah, I think, speaking with the professional or the professionals that you're working with, because there aren't, looking at your benefits as well. But as Dr. Gold said, as you said, you may be able to find someone where you can get some, maybe a less comprehensive or, paring back things a bit to get, at least some screening done. So thank you. We have a question. Which assessment tools do you like to use for executive functions?
Huh. Well,
Dr. Cobley is asking.
yeah. Well, I would say that I do like to look at measures of reasoning, and problem solving and generativity, as well as you know, people's ability to detect patterns or be mentally flexible. And so there are neuropsychological batteries that are kind of good at addressing some of those. And so the Dallas Kaplan executive function system is one that has a large kind of variety of these tests. And there are older tests, some have been used since World War I, that measure these skills as well. And I do work with physicians who are in the community, and they're curious about developing a more sensitive battery for assessing cognitive function in their clients, because they want more than a brief cognitive screening, but they recognize that they're not neurologists or neuropsychologists themselves. And so I've worked with some psychiatrists and family physicians about giving them a couple of extra tools so that they can comment on things like processing speed or mental flexibility. So being able to add a test like the trail making test, or another measure that just gives them a little bit more sensitivity than the MoCA. And so I'd be happy to chat offline about kind of bolstering up one's ability to kind of detect some of those abilities in an office.
Great, thank you. How do we prevent getting Alzheimer's if we have had concussions, as it appears that there's an increased risk for people who have had a concussion?
Mhm. So I would say that there are a lot of risk factors for Alzheimer's disease, and they span from things like obesity, medical conditions like diabetes or vascular disease. Um, and so it's concussion is amongst one of the predictors of who will in later life develop challenges with cognitive aging. And the advice that's given in the medical community is one of optimizing lifestyle. So we know that things like education activities, like learning, stimulating the brain, doing things that are cognitively challenging, like going to a museum and learning something and then teaching someone afterwards, or using Duolingo and learning a new language, or trying to learn a musical instrument. Those are all examples of cognitively stimulating activities that are helpful, as is lifestyle. And so things like getting a good amount of cardiovascular exercise, and as well as strength training, and eating well with a nutritious diet, and sleeping well, taking care of one's mood. Those factors, if we optimize all of them, can help reduce the risk of unhealthy brain aging so that even if we've had things like concussions or a family history of Alzheimer's disease, it helps to reduce the likelihood of those of having challenges with an aging brain. And so, to the best of our ability, I think that that's something we can optimize. And I'd encourage people to try to focus on lifestyle factors because there is a lot of value that can be extracted from optimizing them.
Hmm. Absolutely. Thank you. Uh, 8 months post-concussion, this person is still struggling with mood, attention, and coding, cognitive fatigue, and more. They're asking, would an EEG be helpful to target recovery efforts?
I would say that your clinical symptoms are probably enough information. Um, and so the fact that you're feeling like you're not recovered is important information, and that's clinically meaningful. In the hands of one of your doctors, they might recommend additional testing to see if there's a reason you're not recovering well. But typically, EEG is not used in that way. But it is possible that a test like an EEG could detect that the background activity in your brain, kind of like the rhythms of your brain activity, may be disrupted, indicating that the reason you're struggling with cognition and mood could be related to a brain that's still healing and recovering.
Great, thank you. Next question, is there a length of time where you can say the condition is permanent?
Yeah, that's a challenging question as well. That there have been cases of very long, protracted recovery from concussion. And from the world of athletics, I draw upon Sidney Crosby, who had, more than 12 months of post-concussion syndrome, and he has access to, the best medical care in the world. So it's not a lack of treatment or assessment. And so sometimes there can be longer periods. And I've seen clients over the years who've said 2, 3, 4, 5 years later, they've started to notice symptoms abating. So I don't like to put a number on what's permanent, but I'd say if you're in the range of more than 4 or 5 years, I think it does indicate that something is more stable. But I really don't like to predict the future because I've seen surprises.
Mhm. Great, thank you. Debbie's asking, do you provide guidance on how to improve certain symptoms? Are these then evaluated again after a certain amount of time? Do you see patients and provide guidance, or perhaps your clinic does?
That's a great question. And I think of that as the realm of cognitive clinical neuropsychology as well as rehabilitation psychology. And so one thing I'll do sometimes with my clients is I'll say, let's try doing mindful meditation for a month. And afterwards, let's check in again to see if you're still noticing a particular symptom. And some of my clients who are more competitive might say, well, let's test me again to see if that's led to better performance on that working memory test or that attention test. And that can be used as a way of gaining some sort of objective feedback about how someone's doing. And that can be really encouraging if it's positive. It can be discouraging if it's negative, but it is a way of measuring. So I encourage people to be scientists and to try to develop a particular goal that they'd like to work on and then to measure it to see if they've achieved that goal. And sometimes cognitive tests are a way to do that. But other times I'd say real world measures are also important. So if someone's having difficulty maintaining focus for a 2 hour lecture and we try an intervention like let's use mindfulness again, prevent me from trying to think of an example on my feet. And they're able to maintain concentration for 40 minutes, and then that's their limit. And then over the course of a couple months, they're able to maintain 60 minutes. Then I view that as being a more meaningful kind of outcome measure than if your performance is, half a standard deviation better on a processing speed or sustained attention test. But the test can be used in that way. And if I was working with professional athletes, that's one of the ways that cognitive tests are used to see is there recovery in cognition at the level of a very sensitive kind of distinction as someone's processing speed back to their baseline levels. If so, that provides further support that they are recovered from a cognitive perspective.
Great, thanks so much. How long should be left between cognitive evaluations for cognitive function to establish or evaluate progress?
A great question. I think that 6 months is a reasonable lower end of change, um, and so I would say that that's kind of the shorter, but I think traditionally a year is used as kind of a measure of time has passed, and that's a reasonable amount of time that we can comment on change.
Okay, thank you. I take gabapentin to deal with daily headaches. When I wake up in the morning, I find it difficult to think. And I understand this can be caused by the medication. Would this have a long-lasting impact on my brain?
I would say, of course, I can't comment on medications and how they're impacting you, but in general, I do have experience in training with medications, and gabapentin is actually relatively cognitively neutral. Like it's not a medication that makes you overly obtunded, and so if that medication is causing that kind of sluggishness mentally, it is possible to reduce the dose or to try a different medication for the same purpose. And in general, those effects are reversible. So if we're using a medication and we stop the medication, usually we rebound to the pre-medication baseline. So there's no reason to be concerned about long-term effects of that particular type of medication.
Okay, great. Thank you. Are there any foods that can help improve cognitive function once you've had a concussion?
So I'm also not a nutritionist, and it would be out of my scope of practice to kind of give nutritional advice. But speaking broadly, the things that we've been kind of told that we're supposed to eat are things that are helpful. So a nutritious diet that has lots of fruits and vegetables is believed to be high in nutrients as well as antioxidants, and those have been found to be helpful for brain health. So foods like salmon, for instance, have really good natural fats and proteins in them. It's kind of been shown in the research that a Mediterranean diet is really good for cognitive aging and brain health. So healthy oils like olive oils and proteins and fats that come from things like nuts, as opposed to things like red meat or fried food. So kind of the Canada Food Guide, it provides a good broad kind of guideline, and eating well to the best of our abilities would be a diet that's high in nutrients, high in fruits and vegetables, and lower in things like saturated fats or overly processed foods.
That's great. And there actually is, and it's totally in line with everything you said. Baycrest has a brain health food guide,
Oh, wonderful.
and it's just like a two-pager. So if you go in and Google Baycrest brain health food guide, you can come up with it, and it basically kind of summarizes what you were describing. So.
Mhm.
Okay. Dr. Rizos is asking, while addressing mood, sleep, and pain issues, what cognitive specific interventions can be offered to those who have subjective or objective complaints? Um, so, for example, if they're saying they're foggy, they can't multitask, or having thinking or attention difficulties.
Mhm. Well, I think addressing those things are really important, but they are still brain fog can still be the result of those secondary factors. So things like pain that's currently being treated but still isn't optimized, or sleep that's being addressed but normal sleep hasn't resumed, or mood is something you're working on with a therapist, or you've tried a medication with a psychiatrist. And so those things take time to recover, and sometimes we can't just immediately expect cognition to rebound. It's often the end product of those systems normalizing that we see cognition improve. So I would say that kind of like an experiment where we're moving too many variables at the same time, like my preference would be to optimize those things and then see if cognition is back to baseline thereafter.
Great, thank you. How do repeated concussions affect memory?
There is evidence from a colleague of ours, Robin Green, that individuals like professional athletes who've played in CFL do not cognitively age as well, and they've had multiple brain injuries, and they're more susceptible to kind of diseases of aging, things like Parkinson's or Alzheimer's. And so there is some evidence that individuals who've had multiple brain injuries are at a higher risk for difficulties later in life. But some individuals report of the types of thinking that seems to be impacted, memory does seem to be impacted. And Dr. Green's research has shown that a part of the brain called the hippocampus seems to be not as robust and healthy as those who've experienced less concussions. And so for some individuals, and we don't know why, they are showing difficulties with memory, and that seems to be the byproduct of either the brain injuries or how the brain is recovered from concussion, such that they are experiencing memory difficulties. I also do notice that with some people, if they're not feeling cognitively well, like they're feeling mentally foggy or tired, sometimes they feel like they're having more memory difficulties than they are. And so I think it is important to check in with someone about that, because sometimes our impressions of how we're doing don't necessarily match kind of direct measurable evidence of it. And so as an example I give, when you're feeling really depressed and down, sometimes you might think your memory is really poor, but it's more of a reflection of how you're feeling, combined with having some difficulty with memory. So sometimes subjectively, our memory feels worse than it is, and that could be related to other factors.
Great, thank you very much. I know we are at time. Actually, we're a little bit over time. If you're okay, I'll maybe do just a couple more and
Yeah,
then
happy
we'll,
to. I'm really
okay.
enjoying the questions. I think they're
Okay, yeah,
fabulous.
it's we're getting some really great questions. I have post-concussion symptoms, and anytime I ding my head again, I my brain is slower at picking up information, and I find it difficult to watch movement on a screen. Uh, any idea what causes this?
They think that when people have had multiple concussions, that their threshold for subsequent concussions are lowered. So even smaller impacts can result in concussion. And one example that I've kind of had experience with a client is even the act of sneezing actually induced a concussion. And so why is that? We think that that the brain isn't fully recovered and is more susceptible to subsequent concussions. But these concussions are unfortunately risk factors for future concussions. So I've heard Dr. Tatter or Dr. Tartaglia kind of counsel their patients that it's of the utmost importance to let their brain heal. And if it's an instance of them, jogging and having symptoms resume, then safely walking. Or if it's bicycling, then it would be doing a kind of a recumbent bicycle that's stationary. So just trying to have your brain recover in that way. And in terms of that particular instance of difficulty integrating motion, they think that one part of the brain that might be kind of lagging in its recovery is one of the relay stations in the brain called the thalamus. And so if the thalamus isn't kind of integrating information, things might be happening more quickly than other parts of the brain can put together. And it can kind of produce this sense of kind of uncomfortable that that things seem to be moving too quickly, like that a TV show, the edits seem to be causing a certain degree of nausea? Is this idea that the brain is still not integrating information as well, and as a relay station, it's kind of not relaying different information to the nodes in the brain, and it kind of gives this subjective feeling of it not being enjoyable to watch because our brain isn't keeping up with the information well.
Great, thank you. Okay, here's a quick one. Does OHIP cover the treatment?
Good question. What's your experience, Leslie?
Well, I mean, I guess it depends. If we're talking about a neuropsychological assessment, generally speaking, unless you're getting it through a hospital setting where, as in, seeing you at the Toronto Western, or if someone's coming into a place like Toronto Rehab, but there's not a lot of OHIP covered neuropsychological
Mhm.
assessment. I mean, and then there's also a lot of concussion clinics out there. Um, and I would think that a number of the therapies would not be covered.
Yeah, I was
I'm not
thinking
sure.
that
I guess the
OTs,
physician might be,
yeah,
would
physicians,
be, but
OTs, and PTs, and there are OHIP covered physiotherapy centers that I can think of.
okay,
And so that
okay.
would be maybe a way of accessing that care. Um, but I guess thinking about the things that we've been talking about tonight, I agree that unless you're within a hospital and in like particular like UHN,
Hmm.
even other hospitals in Toronto and um, don't have access to neuropsychology. So
Hmm.
it
Hmm.
is unfortunate.
Yeah. Okay, let's do one more. Nisha is asking, are there any good apps or brain games that we could use to help work on various areas of our cognition when we're several years out from the concussion?
So I get this question a lot because I think these brain games are alluring. I think they are appealing. They make us think like, well, maybe someone's kind of thought of a clever way to challenge my mind. And if you enjoy them, then I would say do it. Subscribe, purchase them, enjoy them. But when we looked at the literature and we've compared people who've used brain training games on different types of platforms, they don't outperform individuals who haven't used them. People tend to get better at the tasks that they're training on. So you might get better at one of my neuropsychological tests, but that doesn't necessarily mean that you'll be able to remember more information from a movie or be able to multitask better. And so the advice that I give people is to try to train the skill that they'd like to improve. So if you'd like practice in sustaining attention, you could try a skill like mindfulness meditation, and there are apps that kind of time your mindfulness and see how long you can go before you notice a distraction, and then you're practicing noticing the distraction and bringing back your attention to the primary goal. And I find those types of practices to be more beneficial than an app. But if you're enjoying the app, then definitely use it. But cognitive stimulation by learning or by taking a course or by practicing kind of listening to the news and kind of teaching someone about something that you've learned. And kind of, I view that as more real world learning, real world cognition. And I think that that has more benefit than kind of getting better at a game that's just a game and it's not something you can kind of translate into daily life.
Hmm. Yeah, yeah, I would agree. Okay, well, I think I better stop us there. There are still a few more questions. Thank you so much, Dr. Gold, for the presentation and answering all of the questions that came in. Just a reminder that there will be a very short survey that comes your way. We really appreciate hearing from you, any feedback that you have. And also, if you would like, because sometimes people will, it does ask if there were any questions that you didn't get answered. So if you did have a question that didn't get answered, feel free to include that in your response on the survey. The only thing is you just make sure that you let us know your email so that we're able to respond because the surveys are anonymous. Otherwise, we wouldn't know how to get in touch with you. Uh, so thank you again. And just a reminder, our final session, uh, before the summer break is on May 28th, and we're actually going to have Dr. Robin Green with us, who is
Hmm.
going to be talking about persisting problems with attention, speed of processing, memory, and executive functions. So thank you again, Dr. Gold, and have a nice evening, everyone.
You too. Thank you, everyone.
Take care.